very much. I have now declared cardiovascular disease is a major cause of death in patients with RA, AS, psoriasis, or psoriatic arthritis. The risk of cardiovascular disease is mediated partly by increased insulin resistance and diabetes. A previous study showed that psoriasis patients have an increased risk of insulin resistance and diabetes. Also, RA patients have an increased risk of insulin resistance and an increased prevalence of undiagnosed diabetes. Insulin resistance may be influenced by disease activity or severity in psoriatic arthritis or RA patients. Regarding the association between DMARDs and insulin resistance or diabetes, for anti-TNF, a previous study showed that TNF-alpha promotes insulin resistance in rodents, and anti-TNF therapy may improve insulin sensitivity and reduce insulin resistance in non-diabetic patients with RA and psoriatic arthritis. As for hydroxychloroquine, an animal study shows that hydroxychloroquine may affect the pancreas and leading to insulin resistance. In a randomized trial, hydroxychloroquine improves insulin sensitivity in non-diabetic persons. However, in another trial, hydroxychloroquine use produced no significant change of insulin resistance in 23 non-diabetic RA patients. Also, hydroxychloroquine reduces DM risk in Taiwanese lupus patients in a dose-dependent manner. As for cyclosporine, a previous study showed it may be a risk factor of diabetes in renal transplant patients. However, its role in rheumatic disease patients is still unknown. This is a previous study published in 2011 in JAMA. This is a large retrospective cohort study conducted into health insurance programs in Canada and the USA. And we found this association was tested among 121,000 patients with RA and psoriasis. As you can see, the hydroxychloroquine and the TNF inhibitor seems to provide a protective effect for diabetes risk. However, in this study, we did not know whether there is a different effect between anti-TNF users with or without concomitant hydroxychloroquine use. And also, we did not know the effect of cyclosporine. In addition, although this is a very large study, this is not a nationwide population-based one. So the objective of this study is to test the association between DMARD use and the diabetes risk in a nationwide population-based cohort of patients with ASRA and psoriasis or psoriatic arthritis. We are focused on the use of anti-TNF, hydroxychloroquine, and cyclosporine, and we use other DMARD users as a reference group. This is a retrospective cohort study. We use claims data from Taiwanese National Health Insurance Database. We enrolled all patients with RA, AS, psoriasis, or psoriatic arthritis initiating any DMARD therapy in at least 3 visits with corresponding ICD-9 codes. The DMARDs include anti-TNF and the conventional synthetic DMARDs, including etanercept, adalimumab, hydroxychloroquine, cyclosporine, methotrexate, sulfasalazine, leflunomide, or azathioprine. We excluded all patients with diabetes diagnosed before the initiation of any DMARD therapy. The outcome was the time from the drug intake stage to the DM diagnosis stage. The DM was defined as with a diagnosis of DM with concurrent prescription of anti-diabetic drug for at least 1 month. The census day was the last day of DMARD prescription. Potential confounders include age, sex, disease duration, Charlson Comorbidity Index, prior use of corticosteroid, and concomitant DMARDs. We divided the enrolled patient into 4 mutually exclusive groups. Around 7,000 patients were enrolled in the anti-TNF group. Of these patients, around half had concurrent use of hydroxychloroquine, another half without hydroxychloroquine use. And we enrolled about 1,000 patients in the cyclosporine group and 27,000 patients in hydroxychloroquine group, and about 50,000 patients in other DMARD group. Here is a baseline characteristic. As you can see, you can find that regarding the age, 6 disease group pre-treatment prednisolone use. They are quite different. They are quite differently distributed among the 4 groups. The incidence of diabetes was highest in the cyclosporine group and about the same in the other 3 groups. Here is the figure of time to event for diabetes risk among different groups. As you can see in the left figure, if we divided the anti-TNF group into those with or without hydroxychloroquine group, we can find that the patient with anti-TNF treated combined with hydroxychloroquine had the lowest incidence of diabetes. But if anti-TNF treated patients without using hydroxychloroquine, their incidence of diabetes is almost the same as cyclosporine group. In the cost proportional regression analysis, as you can see, I marked the significant protective factors in blue words and significant risk factor in red. After adjustment for potential confounders, as you can see that there's a decreased risk of diabetes in patients treated with anti-TNF with concurrent hydroxychloroquine. The hazard ratio was around 0.5, and also in hydroxychloroquine group. Okay. If we stratify patients by the disease duration, we can find a trend to have a decreasing hazard ratio in those with longer disease duration. And if we stratify by disease group, we can only see a significant protective effect in RA patients who treated with anti-TNF and concomitant hydroxychloroquine, and in RA and PSA patients, hydroxychloroquine had protective effect. So we conclude that diabetes risk was lower in patients with RA who treated with anti-TNF with hydroxychloroquine, and also lower in RA or psoriasis and psoriatic arthritic patients who treated with hydroxychloroquine but without anti-TNF agents. And the major strength of this study is to use a nationwide population-based cohort, but the major limitation is the lack of disease activity and severity. This is my end of talk. Thank you very much.
Thank you. So this abstract is now open for questions.
Fink, I have a question. Yesterday there was a poster on a very similar topic from the US. They also found the association protective effect of hydroxychloroquine. They also found protective effect with abatacept, not with the other biologics. Do you have abatacept in your database? Would that be something that you could look at?
And because in Taiwan, the abatacept was launched since 2012, and my database is till 2011, so I cannot show the abatacept data.
Very nice, Vivian Bykirk, New York. Are you able to capture BMI in your cohort, and do people who take hydroxychloroquine have a lower BMI?
Another limitation of the claims data that we did not have the BMI data or even smoking data or drinking, etc. Yes, thank you.
That's probably a very relevant comment about also the bias. I mean, which patients will in the first place receive hydroxychloroquine and how are they characterized compared to the other groups? So I think that's very important to address when you write this up in a paper. Thank you very much.
Thank you.